respected attendees. Good evening, sir. So today we are very happy and that we have got the opportunity to have Duncan sir with us today for the presentation. So he is a consultant medical oncologist in the Bigger Cancer Center, which is under SCCF, Assam, as a consultant medical oncologist. So Dibrugarh. So with this, I would like to request Duncan sir to start his presentation.
Am I audible?
Sir, you are audible.
Okay. Okay. Very good evening to all of you, and thank Padma for the arrangement that he has made for this webinar. And I thank Bayer Pharmaceuticals for supporting this webinar and to have a live discussion about a very important molecule that is used in prostate cancer. So I'll try to share my screen. So my screen is visible, right?
Yeah, sir.
Okay. I mean, it's not moving. I'm not able to move the slides actually.
Sir, click on the slides once.
I'll again stop sharing, okay?
Yeah, just reshare or
Yeah.
sir, try clicking on the slides for one time. Then it will be moving.
Oh, yeah.
Yeah.
Okay. So we will be discussing about the newer advancements, the relatively newer advancements that we have in metastatic hormone sensitive prostate cancer. So these slides have been gifted to me by Bayer for the presentation purposes, and I thank them for that. So we as oncologists are all familiar with prostate cancer. It is one of the most common malignancies among the male population throughout the world. And as we all know, like any other cancer, it starts as a localized disease, then it goes into a locally advanced stage, and then with treatment, new and new mutations get accumulated. And in prostate cancer, there is a phase called castrate-resistant prostate cancer, which is to say that it is almost has become refractory to the conventional hormone therapies. And this castrate-resistant prostate cancer stage is actually the stage uh, which results in worse survival for our prostate cancer patients. So if we can avoid the progression of prostate cancer to this castrate resistant state, only then we can improve the survival of our prostate cancer patients. So that should be our motto whenever we find any new case of prostate cancer. And our main aim should be to prolong the survival of our patients. So as you can see here, the metastatic castrate-resistant prostate cancer has a very dismal overall survival of roughly 5 months. So the best stage where we can treat our patients, obviously if they come in the localized stage, that is well and good. But even if they come in a metastatic state, if we can give them the best treatment in the de novo state or metastatic hormone sensitive prostate cancer state, probably that is the best time when we can improve the overall survival of our patients. So this is a very thoroughly discussed trial, the Stampede trial, which actually uh, assessed the survival in newly diagnosed metastatic prostate cancer in the docetaxel era. And as you can see here, that we have been able to improve the survival of our patients, uh, almost doubling the survival, or should I say the event-free survival of our patients to a significant amount with the addition of chemotherapy, and as you can see later with the addition of androgen therapies. But we can do much better. That is always true for any phase of life or in any phase of work. So we have to improve this, and this is where our effort should go. So they have also studied the role of prostate radiotherapy in metastatic state along with the conventional chemotherapy regimens. If you can further consolidate the prostate treatment, the cancer treatment by adding radiotherapy, and they could find that the low burden diseases actually fared well with the prostatic radiotherapy. However, as the disease has heavy burden, and the burden of disease increases, probably addition of radiotherapy doesn't help much. So we have now a number of options that we have been trying for a very long time, starting from docetaxel, then adding up, then considering abiraterone, enzalutamide, apalutamide, and even adding up chemotherapy and anti-androgen therapy together. And we can find that we have actually improved the at least the event-free survival to a very significant extent. And as you can see here, the hazard ratio of all the mentioned trials are in the ratio in the rate of 0.6 to 0.7, and that is very healthy. But definitely, we are left confused at times. What will be the best combination, or is there any other molecule that is much better than the conventional ones? So as you can see here, that the high volume diseases, the diseases which present very late, and those who have a very heavy burden disease, their addition of chemo and anti-androgen therapy uh, adds a further overall survival benefit in comparison to utilization of only anti-androgen therapy alone. And with a very healthy hazard ratio of 0.63. The overall survival improvement, the median overall survival improvement seems to be in the range of 1 to 1.5 years. However, in the low volume disease, even addition of chemo with the anti-androgen therapy doesn't add much. So this is a very good anti-androgen therapy, the abiraterone, that has been used particularly in high-risk metastatic hormone sensitive, and it showed actually it opened the doorway to utilizing androgen blockades, which can augment the hormonal block that we plan for in patients with hormone sensitive prostate CA. And we all know the important issues of abiraterone, the mineralocorticoid issue. And so we need to add some steroid to abiraterone. And the addition of this has actually counteracted most of the side effects of abiraterone. But yes, a steroid for use for a very long term definitely has its own side effects. Apalutamide is another drug that seems to be better than abiraterone in this setting as well as in the progressive setting. And as you can see here, once again, the trend seems to be very good overall survival benefit. works better in high volume as well as in low volume. Enzalutamide is another such anti-androgen therapy, and which has shown almost similar benefit that we have seen with abiraterone and apalutamide as well. These percentages or P or the hazard ratio seems to differ, but overall there is no cross comparison among these anti-androgen therapies. So we can safely say that these are good drugs and they benefit us to a significant amount. So this is actually a piece one study design, which actually again evaluated the combination, the benefit of combination. For example, combination of standard of care therapy, either the chemotherapy with the hormonal therapy or the addition of radiation. So this doesn't come as a surprise that once again, as you can see, similar trend seems to be reflected in any trial. The combination seems to benefit the high volume disease. In the low volume disease, the benefit doesn't seem to be too marked. Arasen's trial actually has now has tried to place a very innovative molecule, darolutamide. Uh, it's actually similar anti-androgen therapy, and it tried to assess whether the benefit of darolutamide in combination with chemotherapy that we had already assessed with other anti-androgen therapies, how much benefit darolutamide can add with the chemotherapy regimen. So this is a global randomized double-blind phase 3 trial. It utilized metastatic hormone-sensitive prostate cancer and who were candidates for both anti-androgen therapy as well as docetaxel therapy. A significant number of patients were in the trial arm as well as in the control arm. So they had a very good number of patients, almost 1,300 patients. The trial arm had docetaxel 6 cycles along with darolutamide 600 BD, along with the anti-androgen therapy. Either it can be leuprolide, goserelin, or even orchectomy. And the control arm had placebo in place of darolutamide. The primary endpoint was overall survival, and secondary endpoints, they assessed multiple secondary endpoints. But probably most important is time to pain progression and symptomatic skeletal free survival. So they found out that most of the patients, almost 90% of the patients, could complete their 6 cycles of docetaxel. And what is more encouraging is that the adverse events between both the arms were identical. So it didn't add up to any significant adverse events. So let us go deep into the primary endpoint of overall survival. And as you can see here, that darolutamide arm did provide a positive benefit in the overall survival, and with a median OS benefit of 48 point, almost 50 months, with a hazard ratio of 0.68, and definitely a 13 to 15% extra benefit overall survival. So how did it fare in the high risk patients? And as you can see here, the high risk patients did have a very good overall survival benefit. And as you can see in the right upper Kaplan-Meier curve, there is a good separation of the curves. And what is more satisfying to see is that the separation seems to be widening with time. But the most good benefit that I can see here is in the low risk patients. Even in the low risk patients, this combination seems to provide a very good overall survival benefit, and with a hazard ratio of 0.62. If you can remember, in previous trials, we found that they did good in the high risk, but not in low risk. But here, darolutamide seem to benefit both. So if we assess the secondary endpoints, so this combination of darolutamide as well as chemo seem to delay the progression to castrate resistant state. And as I had already stated, the most important probably is time to pain progression. So it did provide a persistent pain-free benefit for a significant amount of time. And as you can see here in the left lower curve, that both the curves seem to widen further. So there is a sustenance of the pain benefit that deltamide can provide. So whether the rapidity of the response is fast or slow, that can be assessed with the time to PSA progression and even by how fast there is undetectable PSA. So as you can see here, the tall columns refer to the deltamide arm, and as you can see here, there is a significant rapidity in the response as well, and it delays the PSA progression. So all these adds up to say that deltamide has a very sustained benefit. There is a persistent benefit, and it allows the patient to have a very pain-free survival for a significant amount of time. So I'm sorry. So this is the same theme that we have seen in the high volume state as well as in the low volume state of metastatic hormone sensitive. So in a way, it works in both high volume and low volume. By high volume, we usually mean more than 4 bone lesions, but this definition seems to differ with different trials. But we can safely say that the higher burden is high volume, and it works in high volume as well as in low volume disease. So the most important thing, however, is whether the patient can tolerate chemotherapy or not. So we need to always assess that. High volume or low volume is very important to determine, because we can actually prognosticate the patient as well and how intense we need to go with the patient. But the most important rule nowadays in oncology is we have to hit them hard and early so that we avoid the progression to castrate-resistant prostate cancer. So we need to discuss our options with our patients. We need to tell them that we have better and better anti-androgen therapies for to assist our patients. And as far as feasible, we need to add up our therapies with no overlapping toxicities so that the patient gets benefit of overall survival as well as a pain-free survival for a significant amount of time. So with this, I thank all of you for patient hearing.
Thank you
Over
very
to
much, sir.
yeah,
Thank you, sir, for this wonderful presentation.
yeah.
And thanks for your valuable time. And looking forward to you for your next endeavor in for
Sure,
your next presentation as well
sure,
as. So thank you very much, sir.
sure.
Uh,
Thank Gautam for the
yes,
invitation.
yes, yes.
Yeah.
Now we will be looking forward to Dr. Venkat Babu sir. He will be joining very shortly. So, with
Okay.
this, I would like to thank you, sir. Bye, sir. Bye.
Okay. Thank you. Thank you.
Hello. Just wanted to inform you that and Dr. Venkat Babu sir will be eh, joining very shortly. So please be there.
Hello, Padma sir. At what time the doctor will be joining? Give me one.
Hello.
Yeah, sir.
No, he will be joining. Please be online for some time. Okay.
Yeah, sir. No
He
problem.
is getting some issues with the internet connectivity. He's in some remote place, so he went to some remote place. From there, he is getting some difficulties. Okay. He said that please to wait for some time, huh?
Okay, sir. By the way, we are live also.
Okay, okay. He will be there only.
Yeah.
Thanks. Sari is joining now. Pradeep sir, can I say, Venkat sir, can I present this one, your slides from my end? Can I share the slides from my end?
Yeah, please, please.
Okay, at first, okay, sir. Okay,
Yeah,
okay,
please do. I have low bandwidth, so I cannot share.
okay. So I just wanted to thank Venkat sir for being here today for this topic. So I would like to request Venkat sir. Venkat sir is senior medical oncologist, Shankara Cancer and Research Institute, Tejpur, and he will be presenting his topic on advancing MHSPC treatment horizons with darolutamide with or without chemotherapy and that evidence. So with this, I'm just sharing the slides. Sir, is it visible? Is it visible, sir? Is it visible, sir?
Not it, Padma. Not it, not it. Not it, Padma.
Okay, I have shared.
I cannot see.
Okay, tech team, can you please tell me whether?
Yes, yes. Now it
Okay, okay.
Sir, your
is
slides are
visible.
visible. I think doctor has some network issue there. That's why.
Now it
Hello. Sir, can you please change the slides?
is
Yeah, it's moving, sir.
visible. Uh,
Hello. Sir, can you please change your network or something else that is more suitable to you because you are freeze. That's all.
sorry, Sorry for the low bandwidth. Am I audible?
Yeah, sir, you are audible. Sir, your voice is breaking.
Sorry. Hello. Mr. Padma.
Sir, your voice is your
Am I
yes, sir, you are audible. Sir, you can do one thing, sir. You can switch off your video, and you can do without your video, so that the bandwidth will not require that much. With video, it takes more bandwidth. Tech team, can you please answer to Venkat sir, because I'll be sharing the
Sir,
slides, so it will be difficult
cannot
for
hear
me
him,
to
sir.
answer.
That's why I cannot hear you.
Okay.
Yeah.
if
Sir, you can switch off your camera because if you share, if yeah, I think it's okay. You can turn it on.
yeah, yeah, yeah.
Yes, sir. You can start, sir.
I'm extremely sorry because I didn't expect that the OPD will go so long, and the net here internet is very slow. So let us start with whatever resources we had. Can I go to the first slide, please? Mr. Padma, can you go to the first slide, please? Yeah. So today we are going to discuss about Aranute. This is a drug without steroid, so which is going to be make a lot of difference in patients with metastatic hormone-sensitive prostate cancer. Next slide, please. I have no disclosures to be made. I have been contacted by Bayer for this meeting. So when we see the evolution of metastatic hormone-sensitive prostate cancer, most of the things we have evolved from single ADT, and then we have charted where we have combined docetaxel with ADT, and then we have this ARPIs, newer generation ARPIs like abiraterone in combination with ADT. And we have this ARCHES trial where enzalutamide has been combined with ADT. And we have then triplets, the PEACE trial, a combination of abiraterone, ADT, and docetaxel. But we do know that it requires a lot of good performance status to give triplet. And most of the prostate cancers are diagnosed in elderly. So not many patients are eligible for the PEACE regimen. In the same way, there is enzalutamide triplet, enzalutamide plus ADT plus docetaxel, that is Enzamet. Now, as we have escalated to the maximum with the three-drug regimen in hormone-sensitive setting. Also, now we have a new drug combination, that is chemo-free regimen, darolutamide plus ADT. Although we are awaiting the final results, let us see the outcomes of Aranode till what are the results that are available. Next slide, please. Next slide, please. Yeah. So one of the most unmet therapeutic need in metastatic hormone sensitive setting is to give the therapy without significant toxicity. Because we have seen the triplet regimens, the DOSI, abiraterone, DOSI, enzalutamide along with ADT. There are a lot of side effects, particularly when we have to deliver chemotherapy. We have to give steroids as well. And steroids in elderly population is not is with a lot of side effects. And we have darolutamide, which is a very potent drug, in combination with docetaxel, and we have seen its efficacy in the Adasens trial. Now, there has been thoughts whether we can give only ARPI, a newer ARPI, without chemotherapy, and whether we can achieve a significant radiographic progression-free survival. And we do know that radiographic PFS is very important in prostate cancer, unlike other cancers like lung cancer, breast cancer, etc., because most of these metastases in prostate cancer are to the vertebra and bones. So the moment there is a progression in the bone or in vertebra, there is a chance of that spinal cord compression can occur and can lead to a lot of toxicities. And that is the reason why RPFS is one of the most important, significant, the end point in many of these trials. So the better a drug can control a progression in metastatic hormone sensitive setting for the longer time, the better would be the outcome. Next slide, please. So darolutamide plus ADT with docetaxel is the standard of care for metastatic hormone-sensitive prostate cancer. We came to know that from the Adasens data, where the triplet DARA plus ADT plus docetaxel has shown both safety and efficacy compared to only ADT and docetaxel in patients with metastatic hormone-sensitive prostate cancer. Now, the next evolution from the trial is Aranode, where they have evaluated darolutamide with ADT versus ADT alone. Because ADT still alone is not a standard of care, but in the patients who might not tolerate any other drug, ADT is still given as a single agent. But in this trial, we can say that ADT alone has been the comparative arm, which is not up to the mark. But the outcomes to know whether darolutamide is working well, so that they have compared with ADT alone to provide a new treatment option for MHSPC without docetaxel. So basically, Aranode is to know whether we can give a docetaxel-free regimen with ARPI with a good results. Next slide, please. So when we see the Aranode, it is a randomized double-blind phase 3 study. It is a placebo-controlled phase 3 study. So darolutamide is given to one arm, and the placebo of the darolutamide has been given along with ADT for the other arm. The randomization is 2:1. The inclusion criteria requires histologically or cytologically confirmed adenocarcinoma of the prostate. And one important setting of this trial is ECOG PS2 patients also have been included, because in real world studies, in real world setting, many of the patients we encounter with prostate cancer, they are of ECOG PS1 and 2. The stratification factors they used were visual metastasis and whether the patient has been a de novo metastatic or from the after receiving the prior treatment. The primary endpoint here is radiographic progression-free survival. The secondary endpoint obviously is overall survival, the time to CRPC, the biochemical progression, that is time to PSA progression, and rates of undetectable PSA. If at all the patient has a very good response, what are the rates of undetectable PSA? And time to pain progression, which is an important parameter in hormone-sensitive prostate cancer. And it is open label darolutamide, and 100% of crossover to open label darolutamide is allowed. Next slide, please. When we see the clinical characteristics of the both arms, Asians also have been included in this trial, nearly accounting for nearly 30%, which is a very important whenever we want to use this molecule in the Asian population. And Gleason scores greater than 8 has been used in at the initial diagnosis. Patients who are upfront metastatic as well as de novo metastatic have been equally distributed. And patients with visual metastasis also have been included, which is important parameter because a majority of times when there are visual metastasis, we hesitate not to use not to use chemotherapy, because we do want to use chemotherapy when their metastatic burden is quite high. So in this cohort, the visual metastasis have been included in nearly half of the patients. And prior therapy was received in nearly 80% of patients in darolutamide arm, in placebo arm 40%. Next slide, please. So as we discussed, the country representation across for this Aronaut trial is, it has included majority of Asian population also. And we can see in the map distribution below the Aronaut, where Asia, Europe, Africa, Australia have been included, whereas other trials, predominantly they are in the Western population. Asian population representation is almost minimal to none. If we see the Vision trial, if we see the Embark trial, or Covaway trial, which is Aberaton trial, Asian representation is almost none. Next slide, please. Yeah. So Asia Pacific region representation we have very well discussed. Chinese nearly 65%, India 60%, Taiwan 15%, Australia 21%, and New Zealand 10%. Even within Asian population, there is a significant representation of Indian population. That is a welcoming gesture from this trial. Next slide, please. So when we see the primary endpoint, that is the radiological progression-free survival, there are nearly 46% of benefit compared to ADT alone when we add darolutamide. So this is such a wide difference in the curves we rarely observe in medical oncology. So this is, and we need to remember, this is a chemo-free regimen. This is darolutamide plus ADT significantly reduce the risk of radiological progression or even death by 46% compared to ADT alone. Next slide, please. And this is quite significant statistically. When we see the forest plot, and among the population that has been stratified based upon the performance status, race, baseline PSA, visual metastasis, almost every parameter has been favored in those groups who have been given darolutamide compared to ADT alone. So no one factor has been touching the line of unity in this forest group. So all the subgroups who have been used have been benefited in terms of RPFS by using darolutamide plus ADT. Next slide, please. So we have seen in this trial at the beginning, the first primary endpoint is RPFS, but there are so many secondary endpoints, which is overall survival, time to metastatic CRPC, time to PSA progression, and time to initiation of subsequent systemic therapy, and time for pain progression, that is symptomatic progression. Although final OS data is not available as of date, it is still mature, but the trend, although we should not discuss statistically till the final outcomes are available, we should not say OS is beneficial. But as of now, as per the data available, OS is trending towards darolutamide arm, and rest of the parameters they have shown significant benefit with darolutamide. The secondary endpoints. Next line, please. So, two important points is time to MCRPC, time to pain progression. And we do know that time to MCRPC is an important parameter in the hormone sensitive setting. The reason is once patient has progressed to MCRPC, the number of options and the treatment response rates are very, very less. The average lifespan of MCRP patients would be less than a year in nearly 50% of patients. So that is the reason we want to give the most efficacious therapy as much as possible in the hormone sensitive setting so that the patient will have longer life, better life, and comorbidity free life, like the bone pain as well as the other significant side effects, including the paraplegia. So, time to MCRPC, we can see the curves are very, very widely separated in the darolutamide arm compared to ADT. And in fact, the hazard ratio is 0.4, which means 60% of patients they are benefiting with darolutamide from progressing to MCRPC. In the same way, nearly 30% of patients they have benefit in terms of pain-free period by using darolutamide. Next slide, please. So these are the other secondary endpoints. The PSA less than 2 at any point time during the time has been much better. That is 62% of patients has achieved with darolutamide compared to ADT alone. Only 18% of patients were able to achieve PSA less than 2, 0.2 with ADT alone. And time to PSA progression has been quite significantly delayed using in the darolutamide arm. We can see the hazard ratio is 0.3, which means 70% of patients have been quite significant delay in the progression to the PSA. Next slide, please. And when we see the number of patients who have achieved undetectable PSA, that is less than 0.2 with darolutamide versus placebo, we can see the bars, the comparison between high volume and low volume disease. Even in high volume disease with visual metastasis, who are approximately 50% in this trial, the response to darolutamide has been quite significant. Approximately 40 to 50% of patients with high volume has been responding, whereas only 1 in 5 patients with ADT has been responding. In low volume, nearly 70 to 80% of patients has been responding with darolutamide. Next slide, please. So patients with subsequent life prolonging treatment, when we see the number of patients requiring, it is almost equal in both the arms. But the number of patients who have been requiring subsequent therapy are only 32% in the darolutamide arm compared to 42% with ADT alone, and that is obviously expected. Next line, please. So coming to the treatment-related adverse events, which are really important in this group of population, the treatment discontinuation rate is one of the main important parameter. And when we see, it is only 6% of the patients who are requiring the permanent discontinuation of darolutamide compared to the placebo. And it is surprising to see that even 9% of patients have been discontinued ADT due to the side effects. So when we see the side effects, it is both due to the ADT and darolutamide together. In the darolutamide arm, because of the better quality of life, the discontinuation rates are quite less. And grade 3-4 side effects have been seen only in 1 in 3rd of patients in both the arms, ADT as well as darolutamide. And median treatment duration with darolutamide is nearly 2 years, whereas it is only 1.5 years with the ADT. Till the data is available. Next line, please. So when we see the most common side effects, obviously anemia, arthralgia have been the most common side effects. We need to monitor hypertension in patients with darolutamide. Next slide, please. Yeah. Fatigue is one of the most important side effects, and it was seen nearly in 2 out of 10 patients in darolutamide, that is 5.5% of patients, whereas in ADT, it is nearly 0.5%. Next slide, please. So the rates of adverse events commonly associated with ARPAs was similar across the treatment arms. When we combine darolutamide and ADT, we can see, although cross-trial comparison should not be done, but if we see the side effects, it's hypertension, mainly it is due to the ADT, like vasodilatation, heart flushing, etc. And the side effects due to the ARPAs, like diabetes mellitus, hyperglycemia, hypertension, fatigue, rash, etc., have been noted, but they account for less than 5%. We can see the percentage of side effects with darolutamide. Almost all side effects are less than 5%, except the cardiac arrhythmias, which accounted for 8%. Next slide, please. In fact, when we see the side effect comparison between both the arms, it's almost equal between ADT and the darolutamide arm, including the cardiac side effects, including the metabolic side effects, and including the biochemical side effects. So darolutamide conferred a positive impact on quality of life. It extended the median time to deterioration of FACT-P score by 5.1 months compared to placebo. So it is the only first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being, and with a good representative population across the globe. Next slide, please. So darolutamide doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially on social, functional aspects. So social and family well-being, emotional well-being, functional well-being, and urinary symptoms. These are the parameters that have been measured in the FACT-P scale, and all are favorable in the darolutamide arm. The conclusion is darolutamide plus ADT significantly improved Next slide, please. Darolutamide plus ADT significantly improved radiographic progression-free survival with patients with metastatic hormone-sensitive prostate cancer, which is the primary endpoint. It also showed benefits across almost all secondary endpoints. It is associated with deep PSA responses, regardless of the baseline PSA, and pain progression, as well as the quality of life. So, darolutamide with plus ADT without docetaxel should become a standard of care for metastatic hormone-sensitive patients, particularly in those who are not fit for the triplets. So, thank you so much. Thank you for bearing with me for the low bandwidth.
Thank
Thank
you
you,
very much,
Mr.
sir.
Padmo and Bayer team.
Thank you very much, sir. Thank you very much. In spite of such challenges, you have joined the meeting. Thank you very much, sir. And one more thing is that next time also looking forward to you for your nice presentation once more. And
Thank you.
thank you, sir. With this, sir, just wanted to know from your end, from your experience, sir, how do you consider means two drug therapy in this means darolutamide and ADT? And in the setup of so in oncology pain is always there as part of the treatment. So if you consider pain and everything altogether, side effects will definitely be there. But if you consider a product or if you consider a medicine where the now lesser the number chances of pain for the patient is there, how do you consider aeronaut in this aspect?
Yeah, see, Padma, whenever we are seeing the patients with prostate cancer, there are two to three important points we consider because they are elderly patients. They come with comorbidities, they come with bone metastasis, and they come with a lot of concerns, particularly whether they will be eligible for chemotherapy at that age or not. So, in young patients, when we say young in prostate cancer, it can be 50 or 60 based upon the geriatric assessment. And if they are fit, definitely we would want to go for chemotherapy based regimen, even with darolutamide combination. But most of the patients who are elderly, who have received prior therapy, who have become metastatic, they want something easy on them. And we also want with a good regimen with lesser side effects. So in those patients, I think this is the perfect regimen. The reason being, darolutamide can be given in almost all the patients with any comorbidities. That is first thing. Second, the usage of steroids will be minimal because we are not giving chemotherapy, particularly docetaxel. The third thing, ADT, anyway we have to give. So the number of hospital visits also be quite less. So definitely this is one of the adaptable regimens in suitable patients.
Thank you very much, sir. Thank you, sir, for your presentation. Thanks, sir. With this, can we close the presentation today, sir? Thanks. Thank you, all the attendees who has presented there. Thanks for attending the wonderful presentation from Venkat, sir. Good night.